Hypoxia and hypoxemia are often used interchangeably. They both refer to the state of low oxygenation. Hypoxia is a generalized term to describe a state of inadequate oxygen supply to tissues or the entire system. This is either due to a decreased supply or an increased demand of the tissues, and hypoxia can be transient or chronic. Hypoxemia refers to low oxygen content in the blood and can be caused by systemic hypoxia. It's defined by any one of the following findings: an arterial PO2 on an ABG of less than 80 millimeters of mercury, arterial hemoglobin saturation of less than 92%, or arterial oxygen content of less than 60 milliliters of oxygen per deciliter. Let's review each one of these in the next slide. Here's a quick review of the 3 essential labs that we've talked about before. Partial pressure of oxygen is consistent with unbound oxygen in the blood. This is oxygen that's been dissolved in the plasma. Oxygen saturation, or SaO2, is the percent of binding sites on an arterial hemoglobin bound with oxygen. This level cannot go over 100%. Pulse oximetry is an indirect measurement of this test. And lastly, oxygen content is the amount of bound and unbound oxygen molecules per unit of blood. This depends on PaO2, SaO2, and hemoglobin concentration. There can be many causes of hypoxemia, and sometimes there's even more than one cause happening at the same time. Let's separate out these causes of hypoxemia based on lung-related disorders and non-lung-related disorders. Any causes of ventilation or perfusion mismatch can lead to reduced oxygen content. In times of low alveolar ventilation, which is synonymous with VQ mismatch, this can result in hypoxia. If there is slow to no gas diffusion, as in alveolar fibrosis or poor perfusion, this can also result in hypoxemia. Non-lung related diseases are important to understand as they create an environment where oxygen is not being transported efficiently, or even if at all. A few examples include anemia, carbon monoxide poisoning, and other types of hematologic disorders that can impact oxygen transport, things like sickle cell anemia, for example. In times of low cardiac output, as seen in the spectrum of systolic and diastolic heart failure, oxygen just isn't being transported due to low ejection fraction. This is frequently called a low output state. Let's briefly review oxygen pressures as they relate to the alveoli. Atmospheric, and we can even say inspired PO2, is about 160 millimeters of mercury, and we can say this is PiO2, or the inspired partial pressure of oxygen. Once it moves through the respiratory tree into the alveoli, the alveolar PO2 decreases to about 100 millimeters of mercury. As it moves into the blood, there's a little bit of a loss you can see. So previously I said that arterial blood is about equivalent to alveolar oxygen, and that was a little bit of a fib just so we could build on some of this information. Arterial PO2 typically takes a hit of about 5 to 10 millimeters of mercury in somebody who is healthy, and this number actually increases with age. This difference has a name. It's called the AA gradient, and again it increases maybe 1 to 2 millimeters of mercury each decade, and it's thought to be due to worsening VQ mismatch as we age due to alveolar collapse, elastin destruction, and subacute disease with aging. The alveolar arterial oxygen gradient, or the AA gradient for short, is one way to assess the integrity of the alveolar capillary unit and help determine the cause of poor oxygen diffusion. The concept of this gradient is helpful in understanding disease processes of the lung and how these diseases can impact oxygenation overall. And with it, we can evaluate lung versus non-lung related causes of hypoxemia. So when assessing somebody with hypoxemia, the calculation of this gradient can be useful in differentiating extrapulmonic versus intrapulmonic causes of hypoxemia, like I said previously. The method to do this is to use an ABG to detect a couple of values, the arterial PO2, the arterial PCO2, and from there, you can use the alveolar equation to calculate, you can use the alveolar gas equation to calculate the alveolar partial pressure of oxygen. And by subtracting the alveolar oxygen from the arterial oxygen pressures, you can quickly and easily figure out if it's within normal limits or if it's elevated. And those are the two main values you're looking for, normal or elevated. But before we go any further, let's see what we can learn from the alveolar gas equation and its relationship to ventilation and arterial PCO2. Because we can't build a probe and place it into each individual alveolus to see how well we're ventilating, we need an equation that helps us calculate the partial pressure of oxygen in the alveoli. The alveolar gas equation, or the PaO2, can be calculated by an online calculator by entering some simple information about sea level, about FiO2, and about atmospheric pressure. And lastly, the other component will be the arterial PCO2. R here stands for the CO2 production in the body, also called the R quotient or the RQ, and this is typically a static number of 0.8. But without getting too far into the weeds, what I'd like to do is look at the components of this equation and then discuss the main relationships at stake. So with keeping everything else stable except PaCO2, we're going to see how these two relate to one another. If I were to rephrase the question is, what is the relationship of arterial PCO2 to alveolar oxygen? So in order to find this out, I'm going to make two columns here, and we're just going to plug in a few numbers here. So when PaCO2 is 40 millimeters of mercury, which is normal, the PaO2 is about 100 millimeters of mercury of oxygen. Now as we increase the partial pressure of CO2 in the blood, just to prove a point, let's go to 60 and then 80 millimeters of mercury. So using this equation, we see that with an elevated partial pressure of CO2, this now goes to 75 millimeters of mercury. And with 80 millimeters of mercury of PCO2 here, this now goes down to 50 millimeters of mercury, and this is alarming territory. So what this tells me is in an alveolus, typically there's a proportion of 40 to 100 millimeters of mercury. So 40 millimeters of mercury of carbon dioxide to 100 millimeters of mercury of oxygen. But as this CO2 rises insidiously, it begins to crowd out oxygen. So what we find is that CO2 will move into the same real estate that oxygen is and create an environment where hypoxia is part of the picture of having a high PaCO2. So in summary, where there is more PaCO2, mainly due to real estate reasons, because there's only so much room inside of the alveoli, there is less partial pressure of oxygen that's associated with it. So this is one of the big reasons why higher levels of PaCO2 in folks that have a history of some sort of chronic ventilatory defect like pulmonary fibrosis or COPD, this is why it's so dangerous. Is it because it creates an environment of hypoxia on top of an acid-base disorder. Okay, really quickly, I don't want this slide to terrify you too much, but when we're evaluating hypoxemia, we need to evaluate the AA gradient to identify the health and functionality of the alveolar capillary system. So hypoxemia within a normal AA gradient over here, if we evaluate hypoxemia, we check an AA gradient, we plug in the numbers, we find that the difference between A to A is within normal range, but somebody is hypoxemic. It means the alveoli and capillaries are healthy, but one is not able to inhale adequately. Or the other reason, which is less common, is there isn't enough atmospheric oxygen available. The illustration shows the division between low FiO2, or perhaps somebody hiking up Mount Everest, and hypoventilation syndromes like opioid overdose, neuromuscular diseases. This is where a patient is unable to inhale adequately, or another disease process would be obesity hypoventilation syndrome. Hypoxemia with a normal AA gradient is treated with oxygen and sometimes mechanical ventilatory support. So let's put that down. Treat with oxygen. On the other hand, hypoxemia with an increased AA gradient most commonly means that there's a VQ mismatch. This is the most common reason of hypoxemia. This means that there's either a reduction in perfusion or a reduction in ventilation, and commonly this aligns well with obstructive lung disease, pulmonary embolism, or some fluid that's obstructing the alveoli, blocking gas diffusion, like blood, water, pus, or protein. This can often be corrected with oxygen. Something else that can be corrected with oxygen is a diffusion impairment. And this is classically due to scarring or fibrosis of the alveoli. This is also seen in COPD and interstitial lung disease like idiopathic pulmonary fibrosis. And lastly, if you give oxygen but it just doesn't happen, it just doesn't improve, this represents more of the extreme spectrum of the VQ mismatch, like a shunt. Here, ventilation is compromised either through fluid, blood, water, pus, protein, some sort of profound alveolar collapse or intracardiac shunt. This cannot be corrected with supplemental oxygen. Cyanosis is a physical exam finding that indicates hypoxemia or low SaO2. It's a bluish hue of the skin and the mucous membranes from increased amount of deoxyhemoglobin in the capillaries and the venules. This is commonly seen in the skin of the lips, nail beds, ears, and malar eminences. We can kind of divide this into two categories: central cyanosis and peripheral cyanosis. Central cyanosis originates from low oxygen saturation of hemoglobin in the entire system. When there is at least 5 grams per deciliter of deoxyhemoglobin present in the blood, we are able to see cyanotic changes to the superficial arteries and veins. And this presents as a purple hue to the lips, the fingertips, and the ears. So that is central cyanosis. Peripheral cyanosis is a local manifestation due to decreased blood flow or peripheral vasoconstriction, and it isn't necessarily indicative of systemic deoxygenation. So one can see this in Raynaud's phenomenon or peripheral vascular disease with venous congestion. This is due to decreased blood flow and doesn't necessarily mean that hypoxemia is present. So all of that said, clinically determining if a patient has central or peripheral cyanosis only from the exam is quite difficult. And sometimes in conditions like cardiogenic shock, there can be a mixture of both central and peripheral types of cyanosis. Pulse oximetry is a simple bedside and office test that can be performed to assess oxygenation. It's important to understand the limitations of this test, especially because we use it so frequently. Pulse oximetry indirectly measures arterial saturation of the hemoglobin, and it's used as a stand-in for SaO2, or hemoglobin oxygen saturation. It's important to note here that peripheral oximetry is not always accurate when compared to hemoglobin saturation. Pulse oximetry indirectly measures red and infrared light waves that reflect off of hemoglobin at a translucent superficial site on the skin with good blood flow. And here we have a fingernail bed. So when we put the pulse ox on a finger, as the illustration shows, one side has a light emitter and the other has a receiver. The light emitter directs red and infrared light downward, and on the receiving end is this photodetector which receives and reads the light waves. Oxygenated blood has a specific light signature, as does deoxygenated blood. And these two signatures of oxygenated versus deoxygenated blood make a ratio, or the onboard computer of the pulse ox is able to make a ratio which can be calculated. This ratio of red to infrared light is translated into a saturation number, as we can see here, where we have a small amount of red light and then a high amount of infrared light, and this ratio the computer calculates is equivalent to 100% peripheral saturation, or hemoglobin saturation, for example. The problem with pulse oximetry is that it is an indirect measurement of SaO2. There is no direct information about hemoglobin concentration, for example, oxygen content, carbon monoxide content, or even alveolar ventilation. It also doesn't measure PCO2, pH, or bicarbonate levels. So for example, a patient with severe anemia from blood loss can have perfectly normal pulse oximeter reading of 100% because it's detecting oxygen saturation in hemoglobin. What's missing is that there's very little hemoglobin in the system because the person has bled out. So what's left is fully saturated, but the person is still quite ill, suffering from hypoxia. In another example, as in low cardiac output syndromes like CHF, hypovolemia, and shock, hemoglobin can still be saturated, but the system is suffering from low perfusion state. So the bottom line is that the pulse ox is not a substitute for arterial blood gases, and it's inadequate for whole picture. Another limitation of peripheral oxygen saturation is in assessing anybody suspect of carbon monoxide poisoning. So a pulse ox can't differentiate carboxyhemoglobin from oxygenated or deoxygenated hemoglobin. The most accurate method in arterial testing is checking for carboxyhemoglobin percentage measurement in the blood. In non-smokers, this can range from 3 to 4%. In smokers, this can range usually under 10%, and anything over 10% is usually where symptoms begin. What's interesting also is the limitations of the other types of oxygen assessments in the setting of CO poisoning. So in carbon monoxide poisoning, even if somebody is near death, their PaO2 will not change. There's no change because this represents unbound O2, which is also looking at alveolar diffusion. And with CO poisoning, there is no alveolar diffusion issue. Unbound oxygen is still present, so PaO2, there is no change. Also, you will see that hemoglobin saturation of oxygen, you will see a mild decrease, mainly due to the occupied sites of carbon monoxide if it's profound. But this will not be a severe decrease. Again, as I said before, peripheral oxygen saturations typically appear normal as they can't differentiate from carboxyhemoglobin. Although interestingly enough, emergency rooms are supplying themselves with carboxyhemoglobin detectors in the same style as a peripheral oxygen saturation meter. So they have small little devices that you can hook up to one's fingernail, for example, to assess carboxyhemoglobin. These are becoming more prevalent and more helpful in acute diagnosis. And lastly, and probably most importantly, is carboxyhemoglobin percentage. This really defines the content of carbon monoxide that's attached to hemoglobin. So in summary, we've spoken about hypoxia versus hypoxemia, normal and elevated AA gradients and what they represent, central versus peripheral cyanosis. We've compared all of these oxygen assessment tools in the setting of normal oxygenation and carbon monoxide poisoning, and lastly, the ups and downs of pulse oximetry and oxygen assessment.